No? Okay, priapism is an erection that won't go away. So it's triggered somehow parasympathetically when you have the injury. Not that that's going to be the first thing I'm checking on an individual, but it's there potentially for a cervical spine fracture. Cervical intervention, either anterior, posterior cervical fusion, sometimes both. So we put them back together and make sure they stay together. Post-op, again, we're trying to get them back into activities of daily living. ADLs, we're not looking typically to get them back into their sport. Rehab management, restrict flexion extension, maintain cardiovascular levels during convalescence. Convalescence is your SAT word for the day. So be a spelling test when this lecture is done. Convalescence during their recovery, their exercise, their therapy. Restore strength and gain available range of motion may be limited depending on surgical technique. So, spinal cord injuries. How can we mess this up? Central spinal cord, anterior spinal cord, depending upon the location in the spinal cord, because your body compartmentalizes how those nerves run as well. Where you damage the spinal cord is going to then control some of the symptoms you see. So, axial load, and/or hyperflexion. We've come forward. We have ligamentous tears through our ligamenta nuchae, interspinous ligaments, and that opens up the possibility for injuring the spinal cord. Observation, they may be unable or reluctant to move unassisted. There may be no residual movement of the extremities. And then we may have something called decorticate or decerebrate posturing. Watching somebody posture is kind of a freaky thing. Oh, I should have filmed that video again. All right, oh well. And we'll talk about what those two terms are. I'll show you images of decorticate and decerebrate when we get a little bit later on. So, functional status, bilateral neuromuscular involvement. Airway and cardiac function must be assessed and maintained. Don't do range of motion tests. And so here's your MRI, where you can actually see how this spinal cord right through here is actually getting impinged upon. Can range from weakness to paralysis. So, central spinal cord syndrome, hemorrhage and ischemia of corticospinal tracts, or trauma to cells within the anterior horn of the cervical spinal cord. So from that, from damaging the anterior horn, or doing something that disrupts the blood flow to that anterior horn, we can disrupt the viability of those nerves. So we have weakness in upper extremities more pronounced than lower extremities. So it's preferential to an upper extremity, so you can actually have the uppers get damaged and the lower still function just fine. In the anterior spinal cord syndrome, which is different, is the anterior 2/3 of the spinal cord has been damaged. From this, we have loss of motor function and pain from that site down, period. So upper and lower are both affected. It's also going to impact your temperature sensation. However, touch, pressure, and proprioceptive function are usually present. So the afferent information, the sensory information outside of temperature, are all really maintained. However, motor function beyond that point is lost. And then transient quadriparesis, transient neuropraxia. You can have spinal cord shock. It's where we actually bruise it. It causes some swelling. That swelling can impinge or cause a disruption in the nervous signals being sent. So you have symptoms stemming from that point on down, episode of bilateral muscle weakness and paresis. The symptoms usually only last about 10 to 15 minutes, but you can have altered sensation, afferents, for up to 2 days. So you've shocked the spinal cord, you've bruised it, you've injured it, but you haven't severed it, and so it's recovering slowly over time. It's kind of like hitting your funny bone and you get that numbing, tingling feeling, or even a sting or burner, which we'll get into soon. It's where you're compressing the brachial plexus and you lose feeling, but you haven't disrupted the nerves, you've just pissed them off. And so they're trying to clean them, they're trying to heal a little bit and reset to start sending normal signals again. Observation, patient may be unable or reluctant to move, just like in the others, and decorticate and decerebrate posturing may be there. Management, this usually subsides on its own with no treatment needed. That's not to say if I have somebody who's demonstrating they have paresis, that they're not going to the hospital either way. But if their symptoms are getting better as that ambulance is coming, then we're good. I've seen this once with wrestling, to where I've had to call somebody in because they got dropped on their neck. So, discernment posturing. Arms and legs are extended and internally rotated. It's usually indicative of a lesion in the bilateral midbrain or pontine regions. So we've got a rupture. If it stays this way, it's indicative of a rupture within the brain itself. Decorticate, and this is where, if you think about the term core in the middle, because they kind of withdraw up in towards their core. They kind of pull in rather than arms out. And this puts a lesion above the brainstem, especially above the red nucleus. So this is, again, indicative of a lesion within the brain. Neither one of these are good things to see. But at times, if you're damaging the spinal cord tract, then you can have people go into posturing and end up coming out of it. So cervical disc diseases. What is this?
Disc, the articular disc.
The inside part.
Oh, the subdural. Am I getting it so close? Subdural.
We talked about discs, and you have the inside part and the outside part. What are the differences in the names? Nucleus pulposus and annulus fibrosus. So the annulus fibrosus is the set of rings, the collagenous rings. They go around the outside. They restrict shear forces. Nucleus pulposus is more compressive force. So pulposus gives that concept, that mental picture of pulp. So if we end up starting to damage or wear out some of these annular rings, then our pulp can start squishing itself out, and we end up having sequestration where we have our pulp oozing everywhere. And that's not the problem. It's not the presence of the pulp squishing out of the disc that's going to give us our issue, but that's going to collapse this disc down to where we are then going to end up having pressure on the spinal cord. So you have a pinched nerve, you have compression on a nerve, you're going to end up with usually unilateral damage to the spine. So you'll end up seeing radiculopathy down one side, because those nerves are being pinched on that side. This is the lumbar spine region here. You can see how this is curving for that lordosis. And on the MRI, you can see how that actually, the bulge from the disc is compressing into the spinal cord. So going in and extruding, and taking out this, and then managing this, the disc after that surgically, is going to help take the pressure off the spinal cord and relieve those symptoms. The catch here is if I take any individual over the age of 35 and do an MRI on them, about 50% of them is going to demonstrate with some kind of disc bulge. Which means just to say that you have a bulge is not directly indicative that that is the source of your pain or your problem.
And does this come with age?
It just, yeah, your body starts wearing down. Once you get old like me, it's all downhill from there. So, sometimes resecting those is a possibility. Other times they look at those bulges and they're like, okay, well, if we can conservatively manage this, if we can work on your core activation, if we can stabilize this lumbar curvature in through here, then that might just kind of correct itself. And so frequently, if you're getting these, your first line of treatment is going to be conservative. You're going to help do some activation, some stabilization, some exercises to help strengthen and stabilize the neck or the lumbar spine if that's where it is. And they may have to get to the point, especially in cervical spine, where they just end up fusing them together. Brachial plexus injury. Roots, trunks, division cords, branches. You remember all of those happy things, right? And you're reminding yourself of those this weekend because you have a final exam coming up. So, if you take an individual who, say, drops their shoulder here to hit, and you get a sudden load across the top of the shoulder, then you are putting a great deal of pressure across the brachial plexus, and you have the potential for creating a palsy, creating a weakness within those nerves. You cut off their electrical signal and everything distal, much like you'd have a C-spine injury, is gonna present with unilateral weakness, loss of feeling, that kind of thing. So they'll come up to you and they'll be like, my arm's dead. I can't move it. I can't feel anything. Well, you need to rule out a C-spine injury, but the difference is if we typically have C-spine, acute traumatic C-spine injuries with facet dislocations, those people are usually on the ground, and there's almost always bilateral involvement. Having unilateral involvement like this, to where it's just one arm, is typically giving you that information that it's outside the spinal cord. But you still need to check and clear that before really moving on, so that you're not making oops and judgments.